Good evening, all. So, today I will be talking about post-exposure protocol for healthcare workers. And my talk will be based on CDC guidelines and National Clinical Consultation Center guidelines. Plastic injury while doing PRP therapy on a patient for alopecia, and then she presented to the emergency department stating that she has got a needle stick injury. So these are a very common scenario that we face day to day in ED when a healthcare worker has been exposed to some or the other kind of a bloodborne infection. So what immediately should be done? Please advise the individual to lightly wash all the needle stick and the cut or the exposed area. All these are supposed to be washed with soap and water. So this removes the virus from the wound itself. Finally, flush splashes to the nose, mouth and skin. Irrigate eyes with clean and saline water. Do not put any other irrigants in the eyes. So what is defined as a potential exposure? The potential exposure is defined when two things are combined together. Firstly, exposure to a infectious body fluid. Secondly, the portal of entry. There should be a portal of entry to the exposed person. What are infectious body fluid? Infectious body fluids are all these which are given over here: blood, semen, vaginal fluid, amniotic fluid, breast milk, cerebrospinal fluid, pericardial fluid, peritoneal fluid, pleural fluid, synovial fluid. And what should have been the mode of entry? Either it should be percutaneous, that is through a needle, exposure to mucous membranes of eyes, mouth, or it can be cutaneous only when the skin is broken or there is a raw wound over here. What body fluids don't constitute to be infectious? Saliva, vomitus, urine, feces, sweat, tears and respiratory secretions do not constitute as infectious until unless the saliva or the urine is visibly blood stained. So all this does not require a post-exposure prophylaxis or does not constitute an infectious body fluid under the classification of infectious body fluid. So you should be having a infectious body fluid firstly, and then there should have been a portal of entry. Both of this are defined as a potential exposure. So what are the risks once it is exposed? Of course, the percutaneous ones will be the most deadliest of all. So out of them, if there has been a hollow bore needle, visible blood on the device, a deep injury, or the device has already been used in an artery or the vein of the source person. So in those cases, the transmission will be around 0.23%. Now the mucous membrane exposure should have been a very large volume exposure, so as to give a risk of around 0.9%. Cutaneous exposures generally don't propose much of a risk, but they must involve non-contact, that is उस स्किन पे चोट लगा हुआ होना चाहिए already. Then only it may constitute a potential exposure. So what tests are to be done in a source person? Very easy. The infections that we are most worried about: HIV, hepatitis B and hepatitis C. So for HIV, we don't wait for a P24 assay. We can do the 4th generation rapid antigen test. That is as good as enough. Any positive should be taken as positive in this for giving PEP. Hepatitis B, HBsAg, if turned out to be positive, should be taken it positive. Any of these two tests can be done on the source person for seeing whether he is infected with chronic hepatitis C or not. Now, what tests are to be done in an exposed person? The first is because of the institutional protocol and other related issues of claims and insurance. So HIV should be done, then HCV, RNA or anti-HCV should be done, and we expect all the healthcare workers to be having been immunized to hepatitis B. So if he has already been immunized with hepatitis B, does he knows his status, that is whether he has been properly immunized or not? Does he know his anti-HBs? If it does not, if it knows his anti-HBs, if it is greater than 10 MIU per ml, then he is well vaccinated. If it does not know, let's get his checkup done by doing a anti-HBs levels. If he is not immunized, then we go in for a HBsAg testing. So do not wait for report of the source person. The PEP should be given within first 2 hours of presentation to the facility. So first 2 hours is the best. Do not wait for the report. The best window of opportunity is within 72 hours. But do not deny PEP if presented late. Now there are few grey areas where a shared decision taking has to be taken into consideration. Suppose the source person is HIV positive. You do a antigen test and you find that HIV positive, but he is already a known case of HIV and he tells that he has been regular on ART and his HIV viral loads are undetectable as per the latest report. So the chances of transmission becomes negligible. So over here you have to take a shared decision along with the exposed person that whether he or she will like to take a PEP or not. Now if individual has got a sharp injury from collection test where the status of HIV person is not known, in general we do not recommend taking a PEP. However, if the exposed person, if the EP says that he wants to take PEP, it should not be denied to him. Do not deny him, give him PEP. The third thing that I want to discuss is a found needle. What is a found needle? Found needle is any needle that is not present in the healthcare setting, but while walking on the road or while packing something in the house, a person got a needle stick injury. So those type of a found needle stick injury do not pose any risk, and PEP is not recommended. Now the source person comes and asks you, the exposed person comes and asks you, sir, what if the source person is in the window period of the HIV infection? Do I still have chances of getting HIV? Once the person, even if he has tested negative for HIV, the PEP is not warranted. However, if the person who is showing features of acute HIV syndrome, which is nothing but a viral prodromal syndrome like any other viral prodrome, if he is having fever, myalgia, body aches, lymphadenopathy, then there may be a shared decision taking of giving a post-exposure prophylaxis. Otherwise, the window period does not have any role in deciding whether to give prophylaxis. It is not warranted at all. Now, what medicines to give in PEP? In my institute, I recommend the following combination. It is tenofovir plus lamivudine plus dolutegravir. So in case if you are having difficulty in remembering all these names, the ideal is to remember only Viropil. Virus plus pill, Viropil, made by MCure. So this contains a fixed drug combination of dolutegravir plus lamivudine plus tenofovir. So this tablet, one tablet once a day, good enough. So what other drugs can be given? So if you see this page, there are columns. This is the first column and this is the second column. So you can choose any of this from the second column and mix it with one of this from the first column. So as I told you, what I like to give is a tenofovir plus lamivudine plus dolutegravir. So this becomes your first combination. You can give tenofovir plus lamivudine plus a lopinavir ritonavir boosted regimen. So this becomes a second combination. In the same way, you can use zidovudine lamivudine plus dolutegravir, or zidovudine emtricitabine plus raltegravir. So these are the various type of permutation and combination you can do depending upon the availability of the medicine. In case the person is a known case of CKD CLD, please do refer him to a medical specialist for further advice. But the first dose has to go within 2 hours. That is in the ideal situation, that is what is supposed to be achieved. How long to take PEP? The PEP is supposed to be taken for 28 days and stop PEP if the source person is declared negative after taking testing. He has tested negative for HIV. Now, when should the exposed person, how should the exposed person be tested, or how often should the exposed person be tested? First, you have tested in 0 week, then you test at 2 weeks, and then you test at 6 weeks, and then you test at 12 weeks. In majority, this 2 weeks is omitted out. And based on institutional protocol, the extended testing may also be done at 6 months. So if the person has already tested negative for in the initial 12 weeks, it is very fair to assume that person has got no or negligible chance of catching the infection. Now, the source person has turned out to be HBsAg reactive. Is it a matter to somehow get anxious for? So what we expect is that all the healthcare workers should have been vaccinated by HBV vaccines. But suppose the individual is not vaccinated. Then individual receives hepatitis B immunoglobulin along with HBV vaccine in the schedule of 0, 1 and 6 months. Now suppose HBV IG is not available to you. So do not stop the vaccination. Please continue the vaccination. Please continue vaccination. HBIG should be given preferably within first 12 hours of exposure. First 12 hours. Now, if he is vaccinated, there can be two scenarios. One in which the vaccination has adequate response, and the other in which the vaccination has inadequate response. In case the vaccination has got adequate response, no management is required. But in case the vaccination does not have inadequate response, then you have to give HBIG as well as hepatitis B vaccine in the same schedule, 0, 1 and 6 months. So how much hepatitis B immunoglobulin is supposed to be given to a person one exposed and he is not vaccinated? The HBIG recommended is 0.6 ml per kg, and this is a stat dose, and to be given in the other arm from which the vaccine is being given. The vaccine is supposed to be given in the one arm and the HBIG on the other arm. Now we come to if the source person has been detected to be HCV positive or has got a detectable HCV RNA in the blood. So the percutaneous risk is around 0.2%, mucosal exposure risk 0%, so PEP not recommended. So when if the exposed person, if he gets infected, the HCV RNA will turn positive within 1 to 2 weeks, and anti-HCV antibodies will become positive in 8 to 12 weeks. At present, there is no recommendations of any PEP to be given when infected to a HCV positive person. So with that, I conclude my today's talk. Please leave your suggestions for new topic as comment. Thank you.